स्वागतम, नमस्कार, केम छो, आदाब अर्ज़, good afternoon, good morning, good evening, depending upon which part of the world you are. आप सभी का PRL के अमृत व्याख्यान और विभा चौधरी मेमोरियल लेक्चर में स्वागत है. A very warm welcome from me, Anil Bharadwaj, for PRL का अमृत व्याख्यान and विभा चौधरी मेमोरियल लेक्चर. This is the 28th Vyakhyaan of the series of Vyakyans, which is being organized as a part of PRL's 75 years of legacy and history in fundamental physics and space sciences. Established in the year 1947 by father of Indian space program, Dr. Vikram Sarabhai, the PRL's Platinum Jubilee coincides with India's 75 years of independence. So it's a joint celebration of development of science and technology in India by PRL under the banner of PRL's का अमृत व्याख्यान. Today is a special day because along with the 28th PRL का अमृत व्याख्यान, we have the second Viva Chaudhary Memorial Lecture. We started this memorial lecture last year, essentially to honor and commemorate the life and work of Dr. Viva Chaudhary, who spent majority of her scientific career in PRL. My colleague, Professor Hiranya Mishra, will be providing you some details about Dr. Viva Chaudhary and her work in PRL. So being a joint Viva Chaudhary and PRL Amrit Vyakhyaan, we have a very distinguished Vyakhyaan or a lecturer, you can say, for today, Professor Gagandeep Kang, who is currently professor at Christian Medical College in Vellore. And she will be talking about prevention is health and wealth. So essentially, her focus would be on her forte of work, and she would make us understand the importance and significance of and the potential of vaccines. Well, viewers and listeners must have seen and heard Professor Kang, particularly in live medias, and more particularly during the current scenarios when we had COVID-19 pandemic. She is the first woman fellow of the Royal Society, and she and I have a common denominator. We both were awarded Infosys Prize in the year 2016. With this, I'll now request my colleague, Professor Hiranya Mishra, to talk to you about Viva Chaudhary and her work in PRL. Over to you.
Unmute.
Thank you, Dr. Bharadwaj. And it's a pleasure and honor to speak about a very distinguished alumni of PRL, Dr. Vibha Chowdhury. Dr. Vibha Chowdhury is the first Indian women particle physicist or cosmic ray physicist, let me tell you. So she grew up in Calcutta, did her MSc from Calcutta University in 1934. And then she joined Bose Institute, working with Dr. Devendra Mohan Bose, D.N. Bose, who actually is the nephew of J.C. Bose, the famous J.C. Bose that we all know, and worked on this finding out fundamental particles using photographic emulsion plates. I told you she was the first Indian women particle physicist, but considering that time, particle physics was still in its infancy, and many new particles were yet to be discovered and were proposed and discovered. And let me tell you one thing, a year prior to that, the Japanese physicist Yakawa gave this, he proposed a particle called pion, but that time it was called mesotron or something, that is responsible, which binds neutron and proton inside a nucleus. Now, this particle was not seen. And that was just the beginning, as I said. And this lady, Bibha Chowdhuri and D.M. Bose, went with photographic emulsion plates to places like Darjeeling and nearby area to get them from cosmic rays. And they got very good results, and these results are this is a pioneering technique developed by both of them and was published in journals none other than Nature. 3 consecutive papers in Nature that was published by these people. And after that, she went to, and it was soon after her MSc. So it is between 1938 and 1942. I mean, during that time, that was the Second World War time. But the photographic emulsion plates that they were using was not very sensitive, and during wartime it was very difficult to get high sensitive, emulsion plates. In 1945, she went to Manchester. By the way, this and they did identify 2 particles, but not very precisely, because, as I said, the photographic plate was not very sensitive. Much later, or rather 7 years later, Powell of Bristol University, Cecil Frank Powell, he used the same technique and discovered pions and muons, for which he got Nobel Prize in 1950. As I said, 1945, she went to Manchester, worked with Patrick Blackett in his lab on extensive air shower experiments, and did very good work. In 1950, she got the PhD. 1951 and 1948, I think, Patrick Blackett got the Nobel Prize for his pioneering work on this extensive air showers. And upon Blackett's recommendation to Bibha joined in TIFR in 1959, and she was there till 1953, working on this various cloud chamber experiments. And then she went to various laboratories in Europe and US, like École Polytechnique, MIT, Michigan, University of Michigan. And after that, in 1959, she comes to PRL. And as CSIR research fellow, RF. And then, of course, she was here till 1976. And at various stages, she was then the CSIR pool officer, and then a fellow of PRL. And during this time, she worked at Kolar Goldfield, tracking muons. And even then, that was the Kolar Goldfield has a great history of detecting of cosmic ray research, including proton decay later. But she was there in all this pioneering work. She was not only a pioneering cosmic ray physicist, she was also an excellent teacher. I mean, I have read about how Kasturi Rangan, our chairman, National Education Policy, is an alumni of PRL and other distinguished alumni, tells how meticulous he was in teaching and imparting originality in thinking, out-of-box thinking. That is what he says. And after he left PRL, he worked in Calcutta with colleagues from Saha Institute of Nuclear Physics, from Variable Energy Cyclotron Center, ISCS, Cultivation of Science Institute, and other colleagues of Calcutta University. And she did many pioneering work, but somehow it was not very much appreciated or He was she was it was only very late. I mean, since last few years, and there is this book that came out. I don't know whether you see. Oh, it's a book on a jewel unearthed by Bibha Chowdhuri, the story of an Indian scientist by Rajinder Singh and Suprakash C. Roy. It's a very nice book, and it tells about her work, and it is since, as Anil was telling, that since she spent most of her scientific career time in PRL, it is but natural to have a memorial lecture in her honor. And this is the second of its lecture. And we have a very distinguished speaker this time. And I won't take much time. I now request Professor Shrubhavati Goswami to introduce the speaker. Shruva, over to you. Shruva, are you there?
Yeah, thank you very much, Hiranmay. And it's a real honor and pleasure for me to introduce today's speaker, Professor Gagandeep Kang. Professor Kang is a physician scientist working on vaccines and public health, particularly focused on children and enteric infectious disease in India. Her interdisciplinary research on the transmission, development, and prevention of enteric infections and their sequelae in children in India has led to new insights and practical approaches to prevention. She has worked with colleagues at the Christian Medical College and other institutions in India to build national rotavirus and typhoid surveillance networks to estimate the disease burden and inform policy. She established laboratories to support vaccine trials and conducted phase 1 to 3 clinical trials of vaccines, a comprehensive approach that has supported 2 Indian who pre-qualified vaccines. She is investigating the complex relationships between infection, gut function, and physical and cognitive development, and seeking to build a stronger human immunology research in India. Based at CMC Vellore for most of her career, she has established strong training programs for students and young faculty in clinical translational medicine, aiming to build a cadre of clinical researchers studying relevant problems in India. From 2016 to 2020, she had been the executive director of the Translational Health Science and Technology Institute, Faridabad, an autonomous institute of the Department of Biotechnology, Government of India, where she developed vaccine science and clinical research as key focus areas. She is an elected fellow of all the Indian science academies, is the first Indian woman to be elected to fellowship of the American Academy of Microbiology and to the Royal Society. Today she is going to speak on prevention is health and wealth, and we will take the questions after her lecture. And so please type your questions in the chat box, both WebEx and YouTube listeners. And with that introduction, it's my pleasure to invite Professor Gagandeep Kang to deliver her lecture. Professor Kang.
Thank you very much, Professor Bhardwaj and colleagues, for inviting me here and for the very generous introductions. I'm going to be talking to you about vaccines, but I think coincidences play a large part in life. Recently, in December, actually, I had gone to Patiala, to Punjabi University there, and there I was presented with a jewel unearthed. And that was the first time I had heard of Dr. Chowdhuri. And it is incredible. She passed away in 1991, and somebody who contributed so much to science from India was not part of our historical canon at all. Everybody knows about Bhabha, everybody knows about Vikram Sarabhai. There are books that have been written about them, which are very informative. But to have a woman physicist written about I think was really incredible. So once again, thank you for the invitation. I'm going to start by telling you about what I do and how I got to thinking on a broader platform. Usually, if you're a scientist who works in a lab, you have the particular problem that you focus on, and your life is around that focus area. And you don't necessarily build the big picture about what role what you are working on plays in the world and what opportunities there are to think about other contributions that we could be making. When I was in the early stage of my career, I was working on enteric infections, and enteric infections as a clinical microbiologist are largely studied in the lab. I had the opportunity to go to the US and worked with one of the outstanding rotavirologists there. I still work with her. And there we started to think about, if there are ever vaccines, what's the best way to make a vaccine? What's the best way to figure out if vaccines are going to work or not? At that time, rotavirus vaccines had been withdrawn because of safety issues with the rotavirus vaccine. A vaccine had been introduced in the US and it had resulted in intussusception, a telescoping of one part of the gut into another. And the US decided to withdraw that vaccine. So in 2000, which is the time that I'm talking about, there were no licensed vaccines that were available in the world. We knew diarrhea was a problem. We knew rotavirus was a killer of children, but we didn't know how to make a better, safer vaccine. So we decided that one way to do this would be if I returned to India and I started to study diarrhea in children, trying to identify what were the differences between children who developed rotavirus diarrhea and those who did not, and to use those immunological signatures from children who did not develop diarrhea to get a correlate of protection, which would inform our development of a vaccine. Now, that's the way much of vaccine development goes. But in order to do this, I had to first establish a birth cohort. And in that process of moving from the laboratory to the community, I really learned a great deal. I learned that rotavirus in our community, which you see in the center of this slide, it's not the worst looking community in the world. There are lots of children. And as we began to work with this community, we discovered some things. We discovered that rotavirus was going to cause diarrhea in 1 in every 2 children if you followed them up for a year. 50% of children would develop diarrhea due to rotavirus in that year. At the time that we started our work, 1 in every 8 children would have a diarrhea that would require an outpatient visit. 1 in 30 children would need to go into hospital, and 1 in 350 children would die. In sitting in Vellore, where there is a big tertiary hospital that I have worked in for years, still in the small cohort of 450 children that I was following up, we had 3 children that died of diarrhea, and 2 of them had rotavirus diarrhea. How did they die? Well, diarrhea is not like seizures. When a child develops diarrhea, they start losing fluid from their bottom end. If they have rotavirus, then they are vomiting also. So you're losing fluid from both ends. And a child that is losing fluid will become lethargic, will stop crying. And when a child does not cry, people don't pay attention to it. So in our neighborhood, 5 kilometers from the best hospital, in the country and certainly in Tamil Nadu, we had children who died of diarrhea. I think it brought home to me the complexity of what disease means to people who are impoverished. Even when care is available, what does it take for people to think about bringing their child to care? Now, one thing that the studies that I did validate for me was that rotavirus was a good problem to choose, because rotavirus, as you can see from the disease pyramid on the bottom of the slide, is a significant problem for Indian children. Our data was validated by other studies. In Kolkata, the GEMS study, the Global Enterics Multi-Site study, showed very clearly that if you had 100 children and you tracked them for a period of a year, between 20 and 25 children in their first year of life would develop moderate to severe diarrhea. So if anything, the rates were even higher than what we had seen in Velo. So we became more ambitious. You can see the map on the top right-hand corner. All of those hospitals are sites where we established the National Rotavirus Surveillance Network, working with ICMR, trying to see whether there was a difference in rotavirus gastroenteritis from one part of the country to another. Essentially, what we found was that viral gastroenteritis is everywhere. And in the first and the second year of life in children, they are going to get a rotavirus diarrhea, and a lot of them are going to wind up in hospital, and a lot of them are going to die. Now, this is viral gastroenteritis. It's easy to treat. You have oral rehydration solution. You can give it to children, they won't get dehydrated. Problem is, viruses cause vomiting. So if you have vomiting and diarrhea, then dehydration occurs. So you need to get a child to a place that can give intravenous rehydration. And in dehydrated children, they're already so small that finding a way to give IV rehydration becomes challenging and they die. Now, what if we had tools to prevent this illness? And that was the goal that we were working towards, trying to understand not just the biology of the virus, the immune response of the virus, but how to develop, how to use a vaccine. So I was very fortunate to work with some leaders in the field. Dr. M.K. Bhan, who was Secretary of the Department of Biotechnology, was a person who developed the first rotavirus vaccine. And he asked us to participate in a study to develop the vaccine made by Bharat Biotech that became Rotavac. This is the vaccine that is in use in India. It's the cheapest vaccine in the world. And now WHO has pre-qualified it so that it can be used around the world. Now, Dr. Bhan, Dr. Krishna Ella shown here, Dr. Vijay Raghavan, who was Secretary, Department of the Department of Biotechnology at the time, were all leaders, and we participated in that, not by developing the vaccine, but making sure that the vaccine was evaluated in a rigorous fashion in both the community and in the field, and subsequently made sure that there was sufficient evidence for the government to make a policy decision. Actually, when we first took the rotavirus vaccine to the government and said, can we introduce this vaccine? They said, we don't need a vaccine for diarrhea. Children in India, diarrhea has come down. It's not really a problem. If we had a choice, we would rather have a vaccine for cervical cancer, a human papillomavirus vaccine, rather than a vaccine for diarrhea. So it's not just about the science, It's also about creating an understanding of what impacts vaccines given in early life can potentially have. And I will come back to that aspect later. Fortunately, the work that we did resulted in the licensure of the rotavirus vaccine, and this was in 2017 for the Rotavac vaccine, and in 2014 for the Rotavac vaccine, 2016 for the Rotacil vaccine, and in 2016 the vaccine was introduced into the program, first in 4 states, then in 9 states, and then in 2019 the program was expanded all across the country. So now we are in a situation where every Indian child receives 3 doses of an oral rotavirus vaccine that is made in India by 2 companies, Bharat Biotech and Serum Institute. Now I'd like to show you the impact of what vaccines can do. And to set up this slide, this is a slide that shows data from Mexico, and this is impact on all diarrheal deaths, not rotavirus diarrheal deaths. In blue is children under 1 year of age, in red is children under 2 years of age, in green is children between 2 and 5. What can you see there? You can see that every year there is a peak in diarrheal deaths, which usually happens in November. It is seen in 1-year-olds, it is seen in 2-year-olds. Then you introduce the rotavirus vaccine in 2007. What happens? The peaks go away, and that is sustained. So Mexico is not a country, it's a country that is higher up on the socioeconomic development indices than India is. And yet in Mexico, you can see a decline in diarrheal deaths. If you look at what happens to diarrhea hospitalizations, you can see in brown the total diarrhea cases and in yellow the rotavirus positive cases. You introduce the vaccine and rotavirus, of course, declines, but all-cause diarrhea also declines, which actually says that our estimates of what rotavirus was causing might be an underestimate. And that we know is likely to be a fact because in about 40 to 50% of diarrheal cases, you can't identify what was causing the diarrhea using routine microbiology or virology. So I told you in India, the vaccines were introduced in 2016, and we had built a network to do the surveillance before the vaccine was introduced. We actually expanded that network post the vaccine introduction. We had a network of 32 hospitals across the country, and we said, let us measure what the impact of vaccine introduction is in India. And you can see here that if you look at the dark blue line, that is the percentage of rotavirus positives. In the dotted line is the vaccine coverage, and you can see the inverse relationship. As vaccine coverage goes up, the incidence of rotavirus diarrhea goes down. So the vaccines made in India are working. This is impact on direct diarrheal disease. And what I'd like to discuss with you is really impact that goes beyond just disease alleviation. Now, in order to do that, I'm going to switch to a more general section of the talk where I'm going to describe to you how vaccines are actually made, what kinds of testing they go through, and then talk to you about the value of vaccination. So if we think about prevention, what do you want from prevention? You want prevention to stop disease. But when we think about prevention from a public health perspective, we think about it in 3 ways: primary, secondary, and tertiary. And today we are going to be talking only about primary prevention, which is use a tool in order to prevent disease or harm before they occur. And vaccination is primary prevention. So we will discuss vaccines, their impact, and their value. So what's a vaccine? We know all kinds of things about vaccines now because of SARS-CoV-2. And we are very lucky that for SARS-CoV-2, we have a vaccine of practically all the kinds of platforms that have ever been used to make vaccines. We have proteins, we have nucleic acids, we have the whole organism, we have vectors, all of which right now are being inoculated. But in the future, we might have vaccines that could be administered to the mucosa as well. So the nasal vaccines being developed by Bharat Biotech and other companies in other parts of the world might be also available fairly soon. You expect vaccines to induce antibodies and cellular immune responses that should protect us against the pathogen and its ability to replicate inside the human being. When we look at vaccine development, we can divide it into early stage or late stage. And the early stage is one that is usually by academia, and the later stage by industry. I talked to you about the work that we were planning to do when I came back to India, which was to identify the mechanism of natural protection by studying children with the disease. And that's the stage that is usually identification of the correlates of protection is usually a task that is undertaken by academia that allows us to identify the antigens that are responsible for generating that correlate. And usually you will try to create an antigen or a vaccine candidate that can be used in animal models to show that the vaccine protects. This is not always possible because sometimes there just aren't good animal models that you can use to demonstrate protection. Then you have to find the best way to present the antigen, and all that we've heard about mRNA vaccines, viral vector vaccines, inactivated vaccines, the protein vaccines like Covovax and Corbevax are all different ways of presenting the antigen. And then, of course, if there are lessons to be learned from other pathogens to predict what matters, then you have a head start. And for SARS-CoV-2, that was certainly the case because we had learnings from the work that was being done on MERS vaccine that we could use in order to develop vaccines for SARS-CoV-2. Once you have all of this information, you can then go to industry, and industry focuses on early stage development, which is to figure out how to make lots of the vaccine that you want to be made, and then to show that it is not toxic and to produce a lot under good manufacturing practice. After that, the vaccine can come into humans, and there is a stage of testing that happens in humans, multiple phases. Now, what are the various kinds of vaccines? I'm just giving you examples. I'm not going to walk you through all of this, but just to say that there are lots of ways of making vaccines, and choosing the best way really depends on what we already know about that organism or related organisms. So we've had vaccines, a variety of vaccines available to us for a very long time. The first vaccine was made in 1796 and is a vaccine that is still available today. So what are the phases of vaccine development? Preclinical phases are animal safety and immunogenicity. If you can induce an immune response in animals and measure that, that allows you to establish the assays. And then vaccines go through phase 1, 2, 3, 4. Phase 1 has very small numbers of people. And the reason for doing this phase testing is because vaccines need to be very, very, very safe. Why? Because vaccines go into healthy people. So while drugs can be used on sick people who might not mind a few side effects, because vaccines go into the general population and go into healthy people, we have to make sure they're very safe. So phase 1, safety and immunogenicity, usually 10 to 100 people. Phase 2 is immunogenicity, usually 10 to 1,000 people. Phase 3 is actually to show whether the vaccine works or not. That's usually 1,000 to 10,000 people. So you can understand that the SARS-CoV-2 trials that recruited between 25,000, 30,000, 40,000, 45,000 people were actually very, very large phase 3 trials. And the reason that they over-recruited was because in a clinical efficacy trial, what you need to do is accumulate numbers of cases so that you can demonstrate the difference between people who were vaccinated and not vaccinated. So let's say you had 10,000 people who were vaccinated, 10,000 people who were not vaccinated, and you expect that 1,000 people without vaccination would get sick. So if in your vaccinated group, only 100 people develop the infection, then the vaccine has 90% efficacy. Now, the problem, of course, is you have to wait for people to get sick. So if you increase the numbers, you're actually increasing your ability to shorten the duration of the trial. It's person time that matters for incidence of disease. So more number of people, shorter duration of study. So that's what was done for the SARS-CoV-2 trials. And then in phase 4, you look at a lot of different aspects, subgroup populations, how does this vaccine perform in immunocompromised, what is the real world effectiveness of the vaccine. So a lot of monitoring that happens after the vaccine is licensed after phase 3 and starts to be used. In preclinical development as well, there is a lot of characterization of the product that needs to be done. And this is critical to make sure that what we are putting into people is reproducible and is of high quality and has its intended effects. Phase 1 studies tend to be studies that don't have a controlled population. And usually in this, you would use only 1 or 2 doses in order to show that the vaccine is really working. In phase 2, you can go into your target age group or into a high-risk population. And this is where you start to have control groups so that you can compare between the control and the vaccinated. So in certain kinds of studies, and what will be very important for the next wave of SARS-CoV-2 vaccines, is to understand how these vaccines will perform in people who have been infected or vaccinated before. Because we've vaccinated most of the world, so ensuring that you have a higher performance will require vaccines to perform in the context of pre-existing antibodies. There are a lot of criteria that are used in phase 2 evaluations, and I'm pointing out all of this to illustrate to you that the development of vaccines is not simple. And the reason why usually vaccines tend to fail. If we start with 10 vaccines in a phase 1 trial, usually only 1 in 7 of those, so about 1.5 vaccines, will make it through phase 3. And you drop a lot for reactogenicity in phase 1, you drop a lot in phase 2 because of inadequate immunogenicity. And then vaccines can fail in phase 3, where they have to demonstrate that they are actually protecting people from disease. There are lots of additional studies that are also done looking at consistency, trying to do bridging studies, especially if you have pre-existing vaccines and you're trying to do a new one. The bridging studies can become really, really complicated. And then you have phase 4 studies, which is something that is critically important in situations that we are in today. For example, if you have a vaccine that was developed against an older version of SARS-CoV-2 virus, will it work when the new variants come? These kinds of studies are called phase 4 studies. Now, what can the impact of vaccination be? I'm showing you two examples here. The first is the example of Haemophilus influenza vaccines in the US. You can see here that a polysaccharide vaccine was made, and then a conjugate vaccine, which allows for a longer immune response, was made and started to be used in children in the 1980s. And Hib disease in children has just disappeared. Now, I'd like you to look at the other set of slides. What you see in the histogram is meningococcal vaccine. And in sub-Saharan Africa, what you have, you have a meningitis belt where every year there would be outbreaks of meningitis A. Once the vaccine was introduced, you can see that if you look at the green line that is shown on top, that shows you the setting up of surveillance and then measurement during the time that they had meningitis cases that were being confirmed, what happened after vaccine introduction. The cases essentially just disappeared. If you look at figure B below, this actually shows you in red Neisseria meningitidis A, which is what the vaccine targets. And in blue and purple, you see meningitis cases that have Neisseria that are not part of the vaccine or non-Neisseria. You can see that nothing is happening to the blue and the purple, but the red after the vaccine introduction has essentially disappeared 2 years after the vaccine was introduced. So this is the impact of vaccination on disease. Now, if we look at impact of vaccines on death in routine immunization in low and middle income countries, these were data that came out from special studies that were done. And now looking at the past and looking towards the future, a vaccine impact modeling consortium has been established that looks at 10 diseases. Those are listed here. 18 different groups looking at the same demographic data and the same vaccination coverage, looking at 98 low and middle income countries, looking at 20 years in the past and 10 years into the future, to try and understand what it means to have vaccines for all of these diseases and to have these vaccines used. And what this shows here is essentially what the picture looked like in 2000, what the picture looked like in 2010, what the picture looked like in 2019. Can you see the difference beginning to emerge? We see the difference first in South America. And if you look at Africa, the color becomes lighter and lighter. These are the numbers of vaccines that are being given to children during these times. And shown here in the graph at the bottom is the coverage of those vaccines. The highest coverage for measles, and then down at the bottom is where you have human papillomavirus, where the vaccines have just about been introduced. So we are beginning to do a better job of protecting our children. And what has been modeled for each of these groups is shown in red. What would you expect to see if you did not have vaccination? And shown in blue is what happens specifically for deaths once you have vaccines being introduced and used with the reported vaccination coverage. Now let's just look at a few things. First, we had already discussed Haemophilus influenza type B, and you can see that in the top row, the second figure. Without vaccination, you have a lot of deaths. Once you have vaccination, those deaths decline. What about human papillomavirus? If we introduce the vaccine, remember this is the last vaccine to be introduced, coverage is still low. But what is the human papillomavirus vaccine trying to prevent? It's trying to prevent infections in adolescent girls, and this figure is measuring deaths. So why don't we see an effect on human papillomaviruses? Because the girls that are getting vaccinated today, the prevention of cervical cancer in them is 20 years into the future, and this modeling only goes up to 2030. So for hepatitis B, which is also a cancer preventing vaccine, and human papillomavirus vaccines, you don't see an impact on death up to 2030. But for every other vaccine that has been introduced into the programs, there is a significant reduction in mortality. And if there is a reduction in mortality, because mortality is the severe end of the spectrum, the amount of disease that is prevented is actually a multiple of the numbers of deaths. So if we look at diseases averted by, deaths averted by disease and countries, children that are born in 2019 will experience 72% lower mortality due to these 10 pathogens over their lifetime than they would with no immunization. And without vaccination, we would have 45% higher mortality than we are seeing today. So vaccines are preventing disease. Vaccines are preventing deaths. But is that all we want from vaccines? Actually, we are beginning to learn that vaccines do a lot more than preventing disease and death. They can protect against asymptomatic infection and colonization. They can therefore protect against transmission, decrease transmission, and result in herd immunity. And vaccines also have non-specific effects that can influence other illnesses. So I'll show you some examples of that. Everybody's heard about herd immunity and whether it works or doesn't work for SARS-CoV-2. But essentially, the important thing to understand is that herd immunity is about populations. If a large percentage of the population is made immune, then transmission will not happen. But that requires a pathogen that cannot infect vaccinated people. So the reason that we talk about herd immunity being hard to achieve for SARS-CoV-2, particularly for the Omicron variant, is because Omicron has the ability to get into previously infected people. Nonetheless, if we were to think about adding an Omicron booster, we might begin to think about herd immunity against SARS-CoV-2 again. Now, vaccines also have been demonstrated to prevent poverty. If you look at out-of-pocket expenditure on vaccine-preventable diseases, World Bank has estimated that actually out-of-pocket expenditure in India is about 63% in 2018. And if your children don't get sick, I showed you the example of rotavirus. Children develop diarrhea, you take them to the local clinic, they don't get better, you take them to the local hospital. And in India, the bulk of spending is really out of pocket. Now, if you spent on a vaccine or the government gave a vaccine before that, it would actually result in savings to the family and to society. So if we think about valuing vaccines, our narrow perspective has always been around healthcare and cost savings around healthcare. But there are broader perspectives as well that the world has begun to think about that I think are critically important. What happens when you give vaccines, and how can we think about that? So I like this really complicated picture. I don't expect you to read all of it, but capturing the value of vaccines. And let's just follow one set of arrows through. So if you are immunized, that results in less expenses, certainly, so more equity, but it also results in reduced morbidity and mortality. When children survive, then family size decreases. You don't need to have 5 children to ensure that 2 will grow to adulthood. And when you have children that are healthy and survive, they grow better and they come into society better educated, more able to work, thereby increasing the workforce supply and the productivity of society. This results in changing an entire nation and its economy. So if we think about the value of prevention, I want you to think about the complexity of this graph. In addition to that, vaccines also impact other diseases. It's been shown that if you get influenza vaccines, if you are a diabetic, then there is a reduction in all-cause death, in cardiovascular deaths, and deaths from heart attacks or stroke. So in a vulnerable population like diabetics, vaccination protects not only against influenza, but also against other conditions that you might develop. Now, I mentioned earlier that for savings, when you prevent vaccine preventable diseases, that results in people not needing to pay out of pocket. Recently, there has been a lot of literature on this, which just shows us that vaccines are a tool for equity. They are a tool for protecting poor households, not only from disease, but also from catastrophic and impoverishing health expenditures. Now, the other thing to remember is that infections can have serious sequelae. So, for example, if you develop a meningococcal infection, that can result in a need for amputation, that can result in neurological sequelae that affect your ability to learn. And it just becomes something that people and their families have to handle for the rest of their lives, even though the infection has gone away. Now, if vaccines can prevent all of these, we should absolutely do that. But in addition to that, there is work that shows that vaccination may impact cognition and educational attainment. So a sick child might not go to school and therefore loses out on learning, but there have actually been studies that show that children who are vaccinated grow better and have better IQs than children who are not vaccinated. The other thing is to think about is that vaccines are prevention, certainly, but vaccines are prevention that is provided by the healthcare program. But if you can promote vaccination, then families that access the health system for vaccination also access the health system for non-vaccine services. So it works in both directions, that if you come in for vaccination, you may come in for other things, or if you come in for other things, it may be possible to vaccinate children if you have an integrated program. And since everybody now worries about antimicrobial resistance and whether we will wind up in a situation where some diseases will be untreatable, vaccines reduce antibiotic use, and there are now data from South Africa and other countries that demonstrate to us that if you vaccinate children against certain kinds of diseases, it results in less usage of antibiotics. And if you have herd immunity due to vaccination, then that results in a further reduction in disease and in antibiotic use. Vaccine preventable diseases like influenza can place a lot of pressure onto a healthcare system. But even something like pneumococcal conjugate vaccine, which is used in children, can have effects that reduce the pressure on the healthcare system. So shown here are two examples, one of what happens when you have influenza and PCV pneumococcal vaccine introduction. Essentially, you have fewer cases, and that results in less pressure on the healthcare system, including for procedures that, children develop a blockage of the ear if they get pneumococcal infections. That requires the placing of a tube inside the ear. And there is data from Finland showing that you get a reduction in both antimicrobial use as well as in tympanostomies if you have a pneumococcal vaccine in the program. So essentially, vaccines have transformed public health. Smallpox, of course, was the first and so far only human disease to be eradicated. In animals, we've managed to eradicate rinderpest. Both of these have been done only with vaccines. It would not have been possible otherwise. But also shown here, the figures in blue are data from the UK demonstrating the effect of vaccines on a range of different infections: measles, polio, Haemophilus influenza, whooping cough, meningococcus, and you can see that when you introduce vaccines, it significantly impacts infectious diseases. So to end, we are all aiming for the global goals for sustainable development, and only goal 3 is supposed to be focused on good health and well-being. I actually think that there are many, many, many more goals: gender equality, quality education, reduced inequalities, that are all impacted by vaccines. And just to take an example of goal 1 of no poverty, if you have immunized healthy children, they grow up to be productive future citizens of countries contributing to strong economies, which results in goal 1 of no poverty. So vaccination, prevention really underpins not just health, but our wealth as well. Thank you very much for your attention.
Thank you very much, Professor Kang, for that very informative and very important talk. Now it is open for a question answer. I request Dr. Professor Kuljit Maharaj to conduct the question answer session, and Dr. Samir Dani and Professor Kuljit Maharaj.
Thank you, Professor Shubhavati. Thank you, Dr. Gagandeep Kang, for sharing wealth of information with us today. You definitely reached us with the latest information and data sets, increasing our curiosity levels to a higher level. Yeah. Furthermore, uh, you will see this in the questions that I see on chat box. But before I invite Dr. Sameer Dhani to take up these questions, I would request the panel members that have joined us on WebEx to raise their hands on the WebEx itself so that I can take up the discussion. Until then, I would request PRL Director Dr. Anil Bharadwaj to kindly initiate discussion with his comments or questions.
Thank you, Kuljit, and thank you, Gagandeep, for a very excellent talk and educating us in this area where our knowledge is quite limited because we don't work in this area, and you have just used very information which is helping us to understand the impact of vaccines and how it is actually improving the society at large. And you also took us to a journey of telling how does it actually supports the economy of the country. I will just have a very layman question in terms of understanding that when people are told to become subject for testing, what kind of difficulties you must be facing, and the hysteria behind that you will be the first person to be given vaccine, and what not can happen to a subject who is given the vaccine for the first time. So how do you handle this, and what kind of scenarios comes up in this area?
So let me start by telling you something else. Do you know that in the UK, hospitals and medical institutions are evaluated by the proportion of their patients who are on clinical trials? The higher the proportion of patients that are on clinical trials, the better your score as an academic institution. Because it is the job of academic medicine to develop the tools that we will use tomorrow, and building the infrastructure to be able to do that with people should be a requirement of every medical institution in the country. Instead, what we have is hysteria. Guinea pig, guinea pig, guinea pig. They're treating me as a guinea pig. They didn't tell me about this. They didn't tell me about that. Well, quite frankly, I think the most important thing to understand in clinical research is that people are not subjects for research. They are participants. They are your partners in research, which means that you have to show them the right kind of respect, and you have to make sure that they understand everything about the study. And we always do a perfect job of this? No, not always. In some of the studies that I've done, I've gone back 7 years, 10 years later to some of the families that participated in my study, were very cooperative, knew everything initially, and I asked them, what were we studying? We were studying diarrhea. What they remember is you gave us free hepatitis B vaccination. So it must have been a study about that, right? So, but I think the critical thing is building trust, building transparency, and communicating frequently. It is a requirement when you're doing a trial that if there is new information, you should communicate it to participants. Many research groups don't actually do that because they view their participants as subjects. You signed up for the trial, I've told you what to do, now you do it, or you give the sample, or you do this. But I think I'm very lucky that I've been in an institution and with a group throughout that has taught us that, rich or poor, everybody is there to be served in one way or the other.
Thank you. Thank you.
Professor Deshpande?
Yeah. Thank you, Kuljit. Dr. Gagandeep, thank you so much for such a wonderful talk. I have three questions. First question is, pertaining to two of your slides. but please excuse me for asking such very naive question. So the slide that I'm referring to is the one in which you had shown the percentage of rotavirus positive cases, which started declining in May 2016. So in that you had drawn one curve with the dotted lines in which it states the percentage of rotavirus vaccinated people. So you stated that the percentage of vaccinated people increased and the infected people decreased. But if we look at that slide, the declining trend in the percentage of rotavirus positive, that decline is occurring right from 2013. So will you please explain to me how I mean how we relate it with the introduction of vaccine? And the same pattern was also observed in your another slide that dealt with the meningitis in Africa. There also it was, the dotted line said that that was the point of, introduction. But the decline
Really,
starts quite earlier. So can you
really
please
good
explain
points.
this?
Very good points. And I'll tell you the problem. Unlike what I showed you in Mexico, where it was a tracking of numbers of diarrhea cases, in India, we start to do studies when we see that there is a problem. So there is no sustained surveillance program where you can say year on year the same quality parameters have been applied. Africa has the same situation. Vaccine is going to be introduced. Now let's start surveillance. For rotavirus, it was very similar. Oh, in these states, rotavirus vaccine is going to be introduced. Now let's add sites there. So what I'm showing you is a composite picture of many sites. But if we break it down by individual sites, the rates of positivity are different across the sites. The trends are all the same.
Okay, fine. Thank you. And then I have two questions which are, more policy related than scientific. The first question is that you say that, when you go to the government for developing a vaccine for diarrhea, then the policymakers had something else in mind, that they wanted to develop the vaccines for, see, papilloma or something else. So the similar kind of things are encountered by other researchers also. You would like to, have launched some research in some field, but then the policy or the system supports something else. So how do you, convince the policymakers?
Well, my general approach to it is to build a watertight case, right? What do you need to be able to introduce a vaccine? You need to show that there is a problem and how big the problem is. You need to have a product that works. So you have to have a vaccine, and sometimes they'll tell you, show that the vaccine works here and there and there and there, right? I don't believe that if it works in the West, it will work in India. Third, the immunization program has to be able to deliver the vaccine, which means they have to have the money, and the vaccine has to be tailored for the immunization program. Now, if all of these can be built up, the next thing is to demonstrate to the policymakers what the impact of introduction is likely to be. So if you have the burden, you introduce a vaccine over this period of time, how much disease will you alleviate? Now, that last piece we don't do very well. We started to do it, we've done it for rotavirus, but that was actually the first vaccine for which it was done. And because we could demonstrate all the aspects that were required for vaccine introduction, we could persuade them. So our usual approach is please, please, please introduce in one state, two states, three states. Then they look at it and then they start to see the impact and then they expand the program themselves. But you have to get your foot in the door somehow.
Okay, thank you. And the last question is, you have shown in umpteen number of cases that the vaccine, prevents, it reduces the number of deaths, and it, protects you against troubles. So having this proved, uh, permitting people not to take vaccination, stating that it is their freedom, So how logically justifiable it is? And one very international player refused to take vaccine, and that was a big thing. So I was just wondering that what is the reason?
Well, I think a lot of people, so there are many concepts that most people have, but I reduce it down to lack of trust in the medical system. And second is very deeply held beliefs about purity and side effects. My body is pure. I should not introduce something foreign into it because I don't know the consequences. So some people go more towards the consequences angle, some people go more towards the purity angle, but that is essentially the spectrum that we have to deal with. And the only way to deal with it is really to listen to what their concerns are, to understand what their concerns are, and try to address them. You will never get anywhere by forcing people because you're not going to do one vaccine and you're finished. That community is going to require much more vaccination. And the more unhappy you make people by ordering a program, the less likely that their community will take up future interventions or trust you. Ultimately, it is trust that you want to build.
Thank you very much, Professor Gagandeep, for answering these questions. I'm obliged. Thank you very much.
Professor Banerjee?
Professor Gagandeep, I have greatly enjoyed hearing you on India Today with Rajdeep Sardesai several times during the last year in panel discussions, and also your articles which have come in Times of India, which I've read on the outbreak of this epidemic. I just have a couple of curiosities. I would like you to look into the future and say something if we've had the Delta variant and the Omicron variant, which have killed a lot of people over the last year or so. So do you think that at the moment it is basically, this is an endemic in India? Or is it still, it can still be considered as a pandemic? Will we have another variant over the next year which will affect people, even though many people are vaccinated now, doubly vaccinated? And finally, for kids who are below 12, what is the government's planning, to get them vaccinated so that they are back in school? I have I have a daughter who's vaccinated. She's in 11th, but my son is in 4th, and he's not been to the school for the last 2 years. So I'd like your opinion, and I thank you again for your talk.
Thank you, Dr. Banerjee. So anybody who tells you that they can predict the future is lying. So we can make conjectures, we can frame scenarios, we can plan for different scenarios, but to predict that this is exactly what will happen, where and when, none of us can do. Will we have more new variants? Yes, we will. When will that happen, and will we be able to handle them? Will they be more severe? Will they infect more people? Don't know. The likelihood is that whatever comes next, given that we now have a strong immune background because of all the exposures and vaccinations, it will need to be something that is particularly infectious. Will it also be more severe? Hope not, but don't know. The question about children, I actually don't think that between 5 and 12 you need vaccines. And my concern with vaccines, so one is, it's not like I'm saying kids should go out and get infected, but we do know that 60% of the children in the country were infected by June, July last year. So at that time, they had antibodies. Many of those antibodies may have declined. Many kids may have gotten infected after that. Most infections in children are asymptomatic, so we don't even know that they've had it. Now, should we vaccinate? Should we not vaccinate? In my thinking, I divide this into two categories. One is thinking about populations and the other is thinking about individuals. If there are any individuals that have a condition that places them at high risk, they absolutely should be vaccinated with whichever vaccine is available. So if you are older, that's a high risk condition. If you have diabetes, that's a high risk condition. Any illness is a high risk condition. Most children don't have these conditions and they are young. So they are at very, very, very low risk. Not zero risk, but very low risk. So from a population level, my thinking about what is it that we can do that is best for our children, to me, that question is, which is the best vaccine for children, right? We have only one in India at the moment. Is it the best vaccine for children? We don't know. And I would like to use the next year or so to evaluate vaccines in children and then make a call on this is what the program should do. In the West, they're using mRNA vaccines for children. So inactivated vaccines and mRNA vaccines are the only vaccines being used in children. Should we not be using vectored vaccine? Well, the risk of thrombosis with thrombocytopenia syndrome is 1 in 65,000 vaccinees. So that's not greater than the risk of many other conditions that happen with vaccines. And yet we are not using that in children. So I think we have a lot to learn. Does this mean your son shouldn't go to school till we figure this out? I think he should have gone to school last year. So, once we knew that so many kids were already infected and we hadn't even realized it, it had not resulted in more hospitalizations, more kids coming to hospital. In our hospital, we've had over 1,000 children admitted with SARS-CoV-2. Okay. The number without comorbidities, I can count on the fingers of one hand. So it is children who have other conditions that have disease that is severe enough to get them hospitalized. Healthy children hardly happens.
Thank you.
Actually, Dr. Kang, that was very good to know that we can send our kids to school now. Now, since I don't see any hand on the panel, I will pass on this forum to Dr. Sameer Dhani, our medical officer, who will take up the questions further.
First of all, thank you, Dr. Kang, for wonderful lecture. Now, I have one question in the beginning. See, H1N1 virus undergoes the mutation every year, so the introduction of the, vaccination against it requires, new strain of virus, particularly under this vaccine. But in case of the COVID virus, mutation happens more than 40 times. But we have been managing the situation with the old vaccine of COVID. So, what is your view?
So I think we need to understand that the vaccines that we made initially, we should consider them wave one vaccines. Whenever you start to make a vaccine, the first vaccine you make may not be the last vaccine that you'll use for programs around the world. There are always improvements. And especially for viruses that change with time, you have to think about, do I want to use a virus that was there 2 years ago, or do I want to use the virus that's here today? Now, actually, there is something called antigenic cartography, which is the mapping of the antigens of the spike protein. So you lay them out so that you can see the ones that are related are close together, the ones that are unrelated are further away. We've actually been quite lucky with the variants that we've had, that Omicron is the first one that is distant from the cluster that is near the old vaccines. So in fact, the alpha variant sits right next to D614G, which is what was used for many of the vaccines, or the Wuhan strain that was used for many of the vaccines. They all sit very close to each other. Delta is at a little bit of a distance. Beta, which didn't take off, is a little bit further away. And gamma is also a little bit further away. But Omicron is that far away. So do we need a new vaccine that's Omicron? Well, if you're going to make an antibody against Omicron, it might protect you only against Omicron and might not protect you against the rest of the landscape. So should we be mixing and matching? We've got plenty to learn.
Okay. Thank you. So now, we have a number of questions. One, very good question from Mr. D. Chakravarti. Since the number of vaccine types exists, how do you determine initially the comparative advantage of particular vaccine type for a new virus? Can there be a racial or demographic dependence?
So if we look at which kind of vaccine should be used for what diseases, the first thing you do is look at related organisms. You know, with SARS-CoV-2, for example, it was easy because we had vaccines that had been tested but not licensed for the old SARS. DNA vaccines, protein vaccines had been made. And then there were vaccines like the Oxford AstraZeneca vaccine was actually being made for MERS coronavirus. They just switched it to SARS-CoV-2. So this was work that was already being done, that was repurposed based on learnings that we had from related viruses. And that's generally the way to go. The reason to think about geographic differences is to think about if there are a difference in either the strains. Vaccines, unlike many kinds of drugs, don't depend quite as much on host makeup because you want to use them at scale in all human beings everywhere. But you can think about region-specific vaccines in some situations. For example, for Ebola. The Ebola that caused outbreaks in West Africa is not the same as the Ebola strain that is seen in East Africa. Do we need separate vaccines for those two? We don't know yet, but we do know that the West African strain vaccines are working.
Thank you. One more question from Dr. Neeraj Rastogi. How do you assess the side effects of vaccine if they occur in a limited number of the people, say it is 100, out of large number of the vaccinated people, example 10 lakhs or more?
Okay, so one of the things that you need to look at is the occurrence of that side effect in the general population, unvaccinated population, and then compare that with the rate seen in the vaccinated population. So for example, with influenza vaccines, we have a risk of anaphylaxis that happens 1 in 800,000 vaccinated people. How can we measure a risk that's so small? We can measure it because the vaccine is given to millions and millions and millions of people. Similarly, when I said that the risk of thrombosis with thrombocytopenia syndrome occurs in 1 in 65,000 vaccinees, actually, initially, when it was identified, it was a bit complicated to figure it out because this is a condition that happens in the absence of vaccination also. So is it related to vaccine? Is it not related to vaccine? To be able to do the causality assessment and then assign vaccine specific rates to it requires that you have lots and lots of vaccinated people compared to unvaccinated people. And this cannot be done in phase 1, 2, and 3 trials. Those measure the common side effects. For rare side effects, the vaccine has to go into large populations.
Yes. Now, there are a crowd of questions, but because of very limitation of time, I could present you only single question. From Vijaya Kumar Sahu, are geographic and demographic distributions of people are taken into account while testing vaccination?
Yes. Vaccine studies in phase 1 and phase 2 can be done in a single location. But in phase 3, usually this is done as a multi-site study because you want the vaccine to be able to be used in multiple environments and in multiple kinds of backgrounds of people.
Thank you. Now, thank you very much, for this interactive session. And back to Kuljit Singh Mara. Kuljit?
So thank you very much. It was really good, but we have a limitation of time. So I now would like to request Ramya Baireddy to give the vote of thanks.
Thank you, Professor Shrupati. First and foremost, we thank our speaker of second Dr. Bibha Chowdhury Memorial Lecture, Professor Gagandeep Kang, for accepting our invitation and delivering a wonderful talk. Thank you very much, ma'am. We convey our heartfelt thanks to our director, Dr. Anil Bharadwaj sir, for his continuous guidance and support for the Dr. Bibha Chowdhury Memorial Lecture Series. We also convey our gratitude to our Dean and Dr. Bibha Chowdhury Selection Committee, who invited most eminent personality, Professor Gagandeep Kang, who is well-known scientist in the field of microbiology and virology. We are also grateful to PRL Amrut Vyakhyaan Committee and Women's Cell Committee for this very informative talk. Without technical support, it is impossible to make it to reach many more audience. We thank our technical team, Dr. Bhushit Vaishnav and Sri Dinesh Mehta, for their technical support in hosting and live streaming the event. Finally, we thank all the participants who joined us from various parts of the world through WebEx and also YouTube channel and made this event a grand success. With this, we are at the end of this Vyakhyaan. Please join us the same time next Wednesday for another Vyakhyaan. Have a very great day.
Thank you so much, Gagandeep.